Bismillahirrahmanirrahim. I'm Dr. Asif Zaidi. I'm Assistant Professor of Gastroenterology, Sheikh Zayed Hospital. I am here with PSH podcast and in collaboration with Firosan Pharmaceutical. Today, our distinguished guest is Professor Zaigham Abbas. Professor Zaigham Abbas is a big name. He works in Karachi at Dr. Ziauddin Medical University and Medical College and hospital as well. So, sir, very warm welcome from my side. I would like you to elaborate us about the role of Dexansopresol and the prevalence of gastroesophageal reflux disease in Pakistan.
Bismillahirrahmanirrahim. Thank you very much for inviting me. And it was a great opportunity to attend Pakistan Society of Hepatology meeting here. And coming to your question, you have asked about two things. One is gastroesophageal reflux disease, and second is role of dexlansoprazole.
Yes,
Is that it? Yeah.
Yes, sir.
So dextroesophageal reflux disease is very common. All of us must have experienced some heartburns in our life. But when these heartburns become very troublesome, then problem arises, and then we call this that these heartburns are influencing our quality of life and making this worse. So it is said that about 10 to 20% of the population do suffer from heartburns, and they have some sort of gastroesophageal reflux disease.
Sir?
The problem in gastroesophageal reflux disease is that, as I mentioned, that it is a common problem, and we should not be very much worried. There are ways to combat this sort of illness. One is the lifestyle modification. That is very important because our lifestyle is changes. We take late evening meals, and then we take a lot of fried things, biryani and kadai and all these things, spicy meals, and we suffer from heartburns that. But lifestyle changes do not always work. Then we come to antacids, and antacids are helpful in mild sort of cases. Then some patients even require some sort of pharmacological therapy. Initially antacids may be there, but then we have to opt for another class of drugs that are PPIs, proton pump inhibitors. Some patients I come across, they require PPI very infrequently, like when they go to some banquet or some marriage party, they take one dose of PPI and that suffices. But many of these patients do require long-term therapy. And the long-term therapy may be that because if you develop reflux disease and there is reflux esophagitis, you need to have long-term therapy for about 8 weeks. That is important to heal the erroneous that may be there. So healing is important in this case, so you have to give PPI for 8 weeks. But sometimes patients complain that they remain okay in the morning, but in the evening they suffer from problem.
Yes.
This may be that these patients are the rapid metabolizers of proton pump inhibitors. They metabolize this rapidly, so there is not enough drug there to act upon in the evening. Then we have to opt a strategy of breaking the dose into two. So we have to give PPIs in the morning and in the evening, so that we are able to maintain a sustained level of drug in our body, and then these patients become better. Another approach may be give PPI in the morning and give some A2 receptor antagonist in the evening, and that approach also works and does work. Another thing is that to choose a PPI that is long-acting PPI. So you asked about dexlansoprazole. The good thing about dexlansoprazole is the capsule has two type of grains. One type of grain is released early, so you get early effects, immediate effects. Second type of grains are they are the sustained release sort of the grains that are there in the capsule. So you get good suppression of acid over 24 hours. So when you are taking dexlansoprazole, most of our patients say that they need not to have a evening dose of PPI, only once a day dose suffice, and they become comfortable with that.
So, sir, how long you want to give this PPI therapy for your GERD patients?
In patients with reflux esophagitis, as I mentioned before, we give PPI therapy for 8 weeks. And 8 weeks, many of these patients are able to heal the erroneous that may be there. Some of these patients do require some low dose therapy later on, sustained, because when they stop the therapy, they develop heartburns again. Because the problem with gastroesophageal reflux disease is that these patients have low esophageal sphincter tone. So they have legs or gapping low esophageal sphincter. So when you stop the therapy, these patients start having reflux again. So to suppress the acid, you have to use some minimum dose of PPIs to keep the acid suppress to a level, and that you do not get symptoms. So about PPI, because many people say that long term you should not use PPI because there are some low quality, I would say, studies are there, and not all these are basically observational studies that show that if you have been on PPI on long run, you may develop dementia, you may develop some osteoporosis, you may develop some kidney problem. So people are afraid of when they do the Google search. So you have to give the minimum dose that is sufficient. Some patients require continuous PPI therapy, some patients require intermittent PPI therapy, and some patients after their reflux esophagitis is healed, they do not require any PPI therapy, and only the lifestyle modifications are enough to keep them symptoms suppressed.
Sir, as you know, in our clinics, every second patient is coming with gastroesophageal reflux disease.
Yeah.
So how will you assess and what are the investigations that you want to do, and what is the role of endoscopy in the patients with gastroesophageal reflux disease?
Because this is a very common problem, and we should not ask for endoscopy, gastroesophageal endoscopy in every case, upper GI endoscopy. But sometimes we do ask for, like if there is a recent onset of symptoms, if the patient is more than 50 or 60 years, and the patient had developed these symptoms for the very first time, this may be one of the indications. If the symptoms are persisting for many months or years, then you should do the endoscopy. If there are red flag sign symptoms, like if the patient is having dysphagia, if patient gives you the complaint, the patient has blood vomiting once, if the patient says that the patient is losing weight, if you examine the patient is anemic, then these are the alarming signs, and alarm signs are when there. You should consult your patient, and you should suggest that this patient should get the upper GI endoscopy done to rule out any severe sort of a problem that may be there or any complication of the reflux problem.
Rightly said, sir. So, what do you say about eradication of H. pylori and the presence of H. pylori when we treat the patient with the antimicrobial therapies? Is the reflux disease worsen with the eradication of H. pylori, or it gets better?
Yes, actually there is difference and controversy. Some people say that when H. pylori infection is there, this keeps the acid suppressed. So when you eradicate H. pylori, and then there is rebound increase in the acid output, and these patients start having the reflux problem. So if this is the scenario, but this does not always occur. This depends on the stage of the H. pylori infection. If the H. pylori infection is antral dominant, antrum, the area of the stomach from where the gastrin is produced, then these patients are producing more gastrin, these patients are more prone to develop peptic ulcer, these patients do have more reflux problem. Then eradication of H. pylori theoretically should be helpful. But if the infection has spread to involve whole of the stomach, H. pylori, then atrophic changes occur, and these patients have suppressed acid output. So when you eradicate H. pylori, stomach epithelium starts recovering, and their reflux problem becomes more severe. So this is not always that when you eradicate H. pylori, the symptoms of reflux would become worse. The problem of the second aspect of your question is about the H. pylori treatment, and we see a lot of resistance of antibiotics that we use. We use clarithromycin, levofloxacin sometimes, but this is documented, both of these drugs. Now the things become resistant. There are some trials of vonoprazan and vonoprazan with amoxicillin. And as you know, the vonoprazan is PCAB inhibitor.
Yes.
It's a new drug, different from PPI drugs. So, but for Pakistani perspective, I would say that we'll have to combine antibiotics with vonoprazan. What we are doing at Ziauddin is the combination of vonoprazan with amoxicillin and tetracycline. So, along with collidobacillin substrate, because we find that, so this is a quadruple sort of therapy. Instead of PPI, we are using vonoprazan for the more effective outcome.
Sir, for the PG perspective, is it safe to mix the vonoprazan along with the PPIs, along with the antibiotics therapy to, like GPs are doing mostly in their clinics?
I think it's not a good practice to give PPI in the morning and vonoprazan in the evening. You have to choose either PPI or vonoprazan because both of these drugs are acting on different sides on the proton pump. And so it's better to use something else with different mode of action altogether. So I would say that better choice would be, if you want to give something twice a day, give vonoprazan or PPI twice a day instead of combining both.
So how long we have to give treatment, and do we really need to think and do the endoscopy to see are there any erosive lesions inside the distal esophagus? Like if somebody is having persistent reflux disease, and you want to get the observational settings of erosive reflux disease inside the distal esophagus, and then you have to treat like 8 weeks or 12 weeks, or you just skip the endoscopy and just treat the patient?
Like if you have documented that this patient has got the reflux esophagitis by endoscopy, there is no need for documentation that you have healed the disease.
Right.
Like if you are given the treatment for 8 weeks, many of these patients improve over 8 weeks of therapy, and these erosions get healed with the 8 weeks of therapy. But if there are other problems that were there, like initially there was, you were not sure about the epithelium of the gastroesophageal junction, whether this was the Barrett's or whether this was the healthy esophagus or unhealthy esophagus lining at the junction. And the biopsies were showing that there is some sort of dysplasia, I would say. Dysplasia means that there are some changes that may be suspicious. Then you treat this patient aggressively for 8 to 12 weeks, and then you do the biopsy again. You want to rule out whether is there any pre-malignant or precancerous change that might have occurred. And because after you have healed the area, if these things are benign, these things should disappear from the biopsy. And when you ask for the take biopsy again, any dysplasia that might be there should disappear. So mild degree of dysplasia get healed with good anti-reflux therapy and with PPI therapy. But if dysplasia persists, that is a precancer condition persists, then that is alarming, and then you have to take the next step. to eradicate that sort of abnormal epithelium. That maybe there are different ways. One way is surgery and one way is ablate the area.
Right.
With
One more question for the PGs, those who are watching. What's your experience about doing anti-retroflex mucosal bending ligations or APC therapy to reduce the area of the lower esophageal sphincter? Is it helpful in treating the patient with reflux disease? ARMB, anti-reflux mucosal bending.
Anti-reflux mucosal bending has been documented, but I have not tried.
All right.
I have not done anything.
Right.
There are other procedures, one procedure is that you do small sort of burns, which is the area
With
make
the
small
argon plasma
burns,
coagulation, yes.
and that area contracts, and then reflux problem decreases. And then other thing is that you put some laparoscopically magnet,
Yes, sir.
small rings of magnet, and this magnet rings keep the area closed. When you swallow, the ring dilates itself, but otherwise magnets come together again and they prevent the reflux problem. Then there are other endoscopy things that may be tried, and then maybe if you have the expertise, but I have not performed that. And one way is the fundoplication that we made endoscopic fundoplication.
Yes.
And the gadgets are available abroad. I am not sure anybody in Pakistan is doing that. That may also prevent the reflux. But before any reflux endoscopy procedure or any surgery, you have to perform certain tests. You want to be sure whether the patient is having actual reflux esophagitis. If there is no reflux, if you don't see any erroneous, then this is a non-erosive reflux disease.
Yes.
So this is a different category. If you see the non-erosive reflux disease, again if the patient is not responding, then you have to do other things before surgery. One thing is the manometry. You want to see whether your food pipe is actually moving in a good way or not, because if you do the fundoplication, if you end up with tightening of your low esophageal sphincter, you may get dysphagia later on.
Yes.
Another thing is the pH impedance studies. That is important because you want to see whether the reflux that is coming from the stomach into the esophagus is actually causing problem or not. Because there are certain things one terminology is esophageal hypersensitivity, and other terminology is functional heartburns. Like if the patient has got the functional heartburns and your pH impedance study is negative, in spite of that patient is having heartburns, these things are not going to respond to the surgery, whatever. You have to do other approaches like behavioral therapy or other things. So you want to be sure by pH monitoring, pH impedance and manometry that your food pipe is in good shape, its movements are normal, its other functions are normal. Another entity that we sometimes see is eosinophilic esophagitis. So it's also important when the patient is not responding to the therapy, you take biopsies from the esophagus and you want to rule out eosinophilic esophagitis. There might be eosinophils in the esophagus. Then these patients do not always respond to the PPI therapy. Then you have to give either locally acting steroids or embark on some elimination diets.
Elimination diet, 6 elimination diet. Professor Zaigham, thank you very much for coming.
Thank you very much.
It's really an honor for me to interview you. Thank you very much, sir.
Thank you very much.
Thank you.